Hello everyone, welcome back to the series of lectures in neurology. Today we will be discussing about motor neuron disease. So let's begin. So what exactly is this motor neuron disease? So motor neuron disease basically refers to a neurodegenerative disorder where the anterior horn cells of the spinal cord are affected. Okay, so this is a neurodegenerative disorder which affects the anterior horn cells of the spinal cord. Okay, fine. So just to give you a perspective of the disease, which famous personality was affected with motor neuron disease? Right, this also has your other name, which is amyotrophic lateral sclerosis. It was Stephen Hawking. Right, so many of you would have seen the Stephen Hawking moving in a wheelchair and predominantly looking very atrophic, looking very cachectic. So the neurodegenerative disorder that he had was this motor neuron disease or amyotrophic lateral sclerosis. Alright, so this is a neurodegenerative disorder which basically affects the anterior horn cell of the spinal cord. Right, so we all know that the anterior horn cell of the spinal cord is predominantly the first part of your LMN pathway. Okay, so this is your first part of the LMN pathway. And this is basically your motor neuron. This is basically your motor neuron. So diseases of the anterior horn cell of the spinal cord are going to affect predominantly only your motor pathways, not your sensory pathways. Okay, clear. Now, what is the hallmark feature? What is the hallmark feature of motor neuron disease is that there is death of the lower motor neurons, the anterior horn cell in the spinal cord. Not only in the spinal cord but also the counterparts in the brainstem and including the upper motor neurons, right? So the lower motor neuron not only in the spinal cord but also the brainstem, okay, and including parts of the upper motor neuron fibers. So the hallmark feature is that there is death of motor neurons, okay, predominantly only motor neurons, and they have both UMN plus LMN features. Very, very important point. It's very rarely that in diseases that we find both UMN and LMN features. Here, because there is degeneration of the lower motor neuron anterior horn cell along with some of the upper motor neuron fibers, there are both UMN as well as LMN features, and it's not only the spinal cord but also the counterpart in the brain stem. Okay, clear? So what about the pathology? What about the pathology? It is characterized by shrinkage of the motor neurons. It is characterized by shrinkage of the motor neurons. There is accumulation of lipofuscin. So if you learn from your pathology classes, lipofuscin is basically a color pigment that accumulates during cell death. So there is accumulation of lipofuscin. Then there can be accumulation of proteins like TDP43. There can be accumulation of proteins like TDP43. And there is formation of spheroids, which are mainly comprised of degenerated neurofilaments which appear as spheroids in your histopathological examination. Right? So there is shrinkage of the motor neuron, accumulation of lipofuscin, TDP43 and spheroids. Right? So the most characteristic of the prototype disease in your neurodegenerative anterior horn cell disease is your ALS. Okay, which was previously called as Lou Gehrig syndrome. Okay, so the prototype disease in your anterior horn cell was your ALS. So what is this ALS standing for? It stands for Amyotrophic Lateral Sclerosis. Okay, so it stands for amyotrophic lateral sclerosis. Okay, so let us understand what is the meaning of each of these words. So what is the meaning of amyotrophy? Where else had we heard of this amyotrophy? We had heard of diabetic amyotrophy. We had heard of segmental amyotrophy in the spinal cord. In our chapter on approach to spinal cord, we have learned that at the level of lesion of a spinal cord, you can have LMN signs. You can have LMN signs which is called as segmental amyotrophy. So amyotrophy here basically means the LMN features which are present. Okay, so this includes atrophy, this includes wasting, and this includes fasciculations. So this includes atrophy, wasting, fasciculations and weakness, which is Amyotrophy means LMN. Then why is it called lateral sclerosis? Why is it called lateral sclerosis? Because there is prominent destruction. There is prominent destruction of the corticospinal tracts, which are carried where in the spinal cord? They are carried laterally, right? They are carried laterally in the spinal cord. So it is called lateral sclerosis. So there is amyotrophic lateral sclerosis, and corticospinal tract involvement will give rise to your UMN signs. Okay, so the crux of the matter in your motor neuron disease is that there are UMN plus LMN signs. So there are UMN plus LMN signs. Okay, so what is the pathogenesis of your motor neuron disease? So what is the pathogenesis of your motor neuron disease? So motor neuron disease can be due to sporadic and it can be due to familial causes. Okay, so you have sporadic as well as familial ALS, and the familial ALS is the one which is usually autosomal dominant in its inheritance. So whenever we speak about motor neuron disease or ALS, we are basically talking only about the neurodegenerative form, not your acquired. Okay, be very clear with that. So here whenever we are saying M and D, we are talking about ALS. Alright, so this ALS can be sporadic or it can be in its familial form. Okay. So the main problem here is that in this familial form, there can be genes which are involved. The genes include genes for your superoxide dismutase. These genes include genes for superoxide dismutase, for example. Okay. Apart from that, you also have your C9orf mutations. So different types of mutations are there. The main problem here is superoxide dismutase. When it is mutated, there is excessive amount of glutamate. There is excessive amount of glutamate, and we know that glutamate is an excitatory neurotransmitter. So there is excitotoxicity. Okay, so you'll have to remember the term excitotoxicity. So there is excitotoxicity and damage to the motor neurons. Fine. So that is one of it. Apart from that, there can be accumulation of misfolded proteins. There can be accumulation of misfolded proteins. Okay, so there is increased glutamate causing excitotoxicity, and there can be accumulation of misfolded proteins, which also results in your damage to the motor neurons. Okay, so this is the basic pathogenesis of your ALS. Now let us look at the etiologies for different motor neuron diseases. So what are all the disorders which can affect your motor neurons? Okay, so you will be very surprised to know that there are so many acquired causes for motor neuron disease as well. So every time motor neuron disease is not specifically ALS. So especially if you see rotations in neurology departments, neurologists are going to evaluate the patient for all these causes before calling them as ALS, because once you give an ALS diagnosis, it is a devastating diagnosis for the patient. Because without treatment or with treatment, the mortality is very high, and they are going to rapidly deteriorate and die within 2 to 3 years, right? So that is the reason why you have to be very careful before labeling a patient as amyotrophic lateral sclerosis. Okay, so always rule out all these etiologies. So what are the other etiologies for motor neuron diseases? Structural lesions like syringomyelia, foramen magnum lesions, parasagittal lesions, predominantly tumors, right? So all of this can mimic a MND. Then infections which affect the anterior horn cell, we have tetanus, Lyme's disease, very important, tetanus, right? Tetanus affects the anterior horn cell, right? We know that tetanus can cause spasticity. It can cause spasticity in the muscles. It can cause spasticity of the jaw, right? So this is because of affection of the anterior horn cell. Then viral disorders include polio, varicella zoster. Polio predominantly causes flaccid paralysis. It causes flaccid paralysis. The other infection includes HIV. Then toxins, lead, aluminium, strychnine poisoning. Strychnine poisoning is very similar to tetanus, right? Because strychnine also affects the anterior horn cells. Then immunologic disorders which can mimic your MNDs includes MMNCB, which is multifocal motor neuropathy. Multifocal motor neuropathy with conduction blocks. Okay, so we have multifocal motor neuropathy with conduction blocks. As the name suggests, there are multiple foci where the motor nerves are involved and it's characterized by conduction block. But here this is also a pure motor syndrome. This is also a pure motor syndrome which is predominantly LMN. Pure motor syndrome predominantly LMN, so this can mimic a motor neuron disease. Then plasma cell dyscrasias, paraneoplastic syndromes, metabolic conditions, hypoglycemia, hyperparathyroidism, very important, vitamin E deficiency, copper zinc deficiency. Okay, all of these can cause myelopathies and all of these can affect the motor cells as well, anterior horn cells. Then hereditary causes, C9orf72 mutations, superoxide dismutase mutations, TDP43 mutations. The C9orf72 is basically associated with a variant called ALS-FTD. ALS-FTD means ALS with frontotemporal dementia. So this is a very bad situation. You have dementia with ALS. Okay, fine. So this is about the various etiologies. Now, motor neuron disease can be classified as purely upper motor neuron having both UMN as well as LMN and purely lower motor neuron involvement. Okay, right? So we have learned the prototype. The prototype is there is both UMN and LMN features, and that is your amyotrophic lateral sclerosis. You can have motor neuron diseases which have predominantly purely upper motor neuron symptoms, and this is called as your primary lateral sclerosis. Like I told you, there is involvement of only the corticospinal tract and hence they have only UMN symptoms. Okay, then predominantly LMN we have your MMNCB. Apart from that we have something called as spinal muscular atrophy. Okay, we have something called as spinal muscular atrophy, which predominantly is an LMN variant of motor neuron disease which affects the anterior horn cells of the spinal cord. SMA, how does it present? It presents mainly in children and it is a common cause of floppy infant syndrome, right? Floppy infant syndrome. Okay, so this is about which is UMN type, which is LMN type and which is UMN and LMN features. Fine. So let us look at the ALS per se. Let us look at the ALS per se. What are the clinical features? What are the clinical features of ALS per se? Okay, so first LMN signs are usually the most predominant in the early stages. Okay, so LMN signs are usually most predominant in the early stages and it has an asymmetric type of weakness. So LMN changes are usually most predominant in the early stages and it begins as an asymmetric weakness, right? So it may present as an innocuous foot drop. It may present as an innocuous foot drop, right? Foot drop. So if the patient is having foot drop, the patient will have tripping over objects. So that is how initially they might present. Okay, and a characteristic early feature is this history of cramping. History of cramping, especially on waking up. Cramping on volitional movements, especially on stretching, on waking up. Okay, so the early waking hours when we stretch and the muscle goes into cramping because this is because of the degeneration of the motor cells. So motor anterior horn cells of the spinal cord, there will be initial stages of hyperexcitability resulting in cramping. A very characteristic feature is this fasciculations. What is fasciculations? Fasciculations basically means involuntary contraction of the muscles. Okay, so you can have fasciculations, which means that there can be minor involuntary contraction of the muscle. So this particular fasciculation is always appreciated on wasted muscles. It's always appreciated on wasted muscles. Very important point. So this is always appreciated on wasted muscles. So wherever the muscle is wasted, you can find this kind of involuntary movements, worm-like movements, which is your fasciculations. Okay, so atrophy is a very important element sign that you can find in your ALS. Then in the hands, the extensor muscles are more commonly involved than the flexor muscles. Okay, so extensor muscles are more commonly involved in the flexor muscles. Then UMN involvement, as the disease progresses, there will be human features as well because of degeneration of what? Because of degeneration of corticospinal tracts. So what are the human features? You can have spasticity, right? You can have spasticity, right? You can have spasticity predominantly. Apart from that, you can have hyperreflexia. So whenever you examine a patient of ALS, you can find areas of spasticity, you can find areas of atrophy. They don't go hand in hand, right? We know that UMN does not have wasting and LMN does not have spasticity, right? So this is because of the combined features. So you may find that you are having hyperreflexia in atrophic areas. That is highly unlikely because LMN signs should have areflexia, correct? So this is how the patient will present. Then degeneration of the corticobulbar fibers. There can be degeneration of the corticobulbar fibers. What do the corticobulbar fibers carry? They are UMN fibers to the cranial nerves. They are the UMN fibers to the cranial nerve nuclei, right? So if that is lost, you can have cranial nerve weaknesses as well, a UMN type of cranial nerve palsies. Clear? Okay. Then sensory and autonomic disturbances are never found. Sensory and autonomic disturbances are never found, right? Also, there is no bowel and bladder involvement, and many a times, right? You have to very clearly remember, patient is completely aware because cognition is not going to be affected. So patient is going to be completely aware of what is happening, and that is why this makes this situation even worse, right? They are completely aware that they are becoming bedbound so rapidly, they are becoming dependent so rapidly, right? And extraocular muscle involvement, that is also not there. So there is no sensory, no extraocular muscle involvement, cognition is not affected, bowel bladder will not be affected. Okay, fine. So this is about the various clinical features of amyotrophic lateral sclerosis. Alright, so then the next clinical feature is there is degeneration of the corticobulbar fibers. Degeneration of the corticobulbar fibers. So what are the corticobulbar fibers? What are the corticobulbar fibers? They are basically your UMN to the cranial nerve nuclei, right? So they are the UMN fibers to the cranial nerve nuclei, right? So if these corticobulbar fibers are affected, what will happen? You can have UMN type of cranial paralysis, cranial nerve paralysis, right? So what is predominantly affected? You can have UMN type of facial palsy. Okay, so you can have bilateral UMN type of facial palsy. We had learnt about element type of facial palsy, bilateral element facial palsy in GB syndrome. Here you can have bilateral UMN type of facial palsy. How do you differentiate between the two? We will be seeing. Also, if the UMN fibers to the bulbar cranial nerve are affected, if the 9, 10, 11 cranial nerves are affected, you can have dysphagia, you can have dysarthria, you can have dysphonia. Okay, right? So all of this is going to predispose to aspiration because you will not be able to swallow. Whatever you swallow, you will aspirate it, right? So this is going to predispose to aspiration pneumonias. It's going to predispose to aspiration pneumonias, right? So whatever you swallow or whatever you drink, this can have nasal regurgitation, you can have difficulty in swallowing, you can have dysarthria as well. So these are the features of your degeneration of corticobulbar fibers. Then sensory involvement. Will there be a sensory involvement in your ALS? No, because there is degeneration of the motor neurons, there is no sensory involvement. What about the bowel and bladder? In the later stages, you can have bowel and bladder involvement, especially in your UMN type of bladder involvement can be present, right? So you can have incontinence, and it's mainly a spastic type of bladder can develop in the later stages of ALS. Then extraocular muscles are never involved, and another very important aspect which is never involved is your cognition. That is why ALS is a devastating diagnosis, because the patient is aware of what is happening, right? Because the cognition is usually not impaired. Okay, so generally an ALS patient usually begins with very subtle motor signs, maybe like a foot drop element type of weakness, and it progresses rapidly. And you can have involvement of all the muscles. You can have involvement of all the muscles with spasticity, and they soon become wheelchair bound and they can become bed bound as well. Bulbar involvement can be even more dangerous. It can present with 9, 10, 11 cranial nerve palsies, dysphagia, dysphonia, dysarthria. They will not be able to swallow, nasal regurgitation. Okay, fine. So this is about the various clinical features of ALS. So you have a combination of both LMN as well as UMN signs. Alright, and there you have to be aware of certain rare variants which are little difficult to diagnose. For example, your bulbar onset ALS. Bulbar onset ALS. So this is very rare and very difficult to diagnose, your bulbar onset ALS, because it predominantly presents only with cranial nerve palsies, and they can have weakness of the respiratory muscles, weakness of respiratory muscles, and hence they will be on a ventilator, and this is also very rapidly progressive, right? So bulbar onset ALS is a rarer variant. Okay, fine. So this is about the various clinical features of ALS. Now, another term that we should be aware of is this term called pseudobulbar palsy. Okay, is this term called pseudobulbar palsy, and what is the difference between pseudobulbar palsy and bulbar palsy? So like I had told you, there can be degeneration of not only the corticospinal tracts, but there can be degeneration of the corticobulbar tracts. Okay, bulb basically refers to your brainstem. So corticobulbar fibers are UMN fibers to your cranial nerves. So if those tracts are affected, the kind of palsy that you get is your pseudobulbar palsy. Bulbar palsy basically refers to when there is LMN type of cranial nerve weakness. So the cranial nerves themselves or the nuclei are affected in the brainstem, then this is called as bulbar palsy. Pseudobulbar palsy is when your corticobulbar projections are affected. Okay, fine. So in your pseudobulbar palsy, most often let us say your cranial nerves 9 and 10 are going to be affected, right? So what are the symptoms that both bulbar and pseudobulbar palsy are going to present with? So the pseudobulbar palsy will also present with dysphagia and dysphonia. Okay, because of 9th and 10th cranial nerve involvement. So this can also present with dysphagia and dysphonia. Fine. But what about the gag reflex? We know that the gag reflex is carried by the 9th cranial nerve. So whenever you do a gag reflex, this is going to be exaggerated. Why? Because the UMN fibers are affected. There is going to be an exaggerated gag reflex in a pseudobulbar palsy. In a bulbar palsy, the gag reflex is lost. What about the speech? You have a strained quality of speech. Here the speech is a flaccid speech. It is a flaccid speech. Here you have straining, which means that this is pseudobulbar in effect. Okay. So this type of dysphonia is a strained dysphonia for a pseudobulbar palsy. Right. What about the tongue? Okay. So cranial nerve 12, if it is involved, how is the tongue going to be? The tongue is going to be small and spastic. The tone is going to be increased. The tongue is going to be stiff and small in a pseudobulbar palsy, whereas here the tongue is going to be flaccid. Okay, the tongue is going to be flaccid. The jaw jerk will be exaggerated. in a pseudobulbar palsy, whereas the jaw jerk is going to be lost. There is no change in the jaw jerk in your bulbar palsy. Then emotional. There is excessive emotional lability. In a patient with ALS because of this pseudobulbar palsy, where they will be crying or laughing for no reason. Okay, so this emotional lability is a characteristic feature of pseudobulbar palsy in ALS, which is absent in your bulbar palsy. So basically your bulbar palsy can be seen with what? It can be seen with brainstem strokes. Your bulbar palsy is what you see in your lateral medullary syndrome, right? So this is all because of affection of the nuclei or affection of the cranial nerve per se. But in pseudobulbar palsy, the UMN corticobulbar projections are affected. Okay, so this is actually how you differentiate your bilateral UMN facial palsy from your bilateral LMN facial palsy. Okay, so this kind of features of pseudobulbar palsy, remember, exaggerated gag reflex, exaggerated jaw jerk, and a strained voice and a spastic tongue, all of these features are features of pseudobulbar palsy. Okay, clear? So this is about pseudobulbar versus bulbar palsy. Pseudobulbar palsy is what we see in motor neuron disease. So pseudobulbar palsy is what we see in motor neuron disease. Okay, fine. Now, let us move on. Now, what are the complications that a patient can have as the disease progresses? Because of this pseudobulbar palsy, because your 9, 10, 11 cranial nerves are affected, they can have recurrent episodes of aspiration pneumonia. They can have recurrent episodes of aspiration pneumonia requiring frequent hospitalizations for your pneumonia, right? They can have frequent hospitalizations. So, after a point in time, the patient has to be on a Ryle's tube. After a point in time, the patient has to be on a Ryle's tube, right? You cannot directly feed them because whatever they eat, it may go into the lungs. Then there can be weakness of your diaphragmatic muscles. There can be weakness of your diaphragmatic muscles or respiratory muscles, right? So finally, this results in a type 2 respiratory failure. Finally, this results in a type 2 respiratory failure where you have hypoxia, decreased oxygen with carbon dioxide retention. Okay, so it is treated with the help of a non-invasive ventilation such as your bi-level inspiratory positive airway pressure, which is your BiPAP. Okay, so you may have to give a non-invasive ventilation such as a BiPAP, so for your type 2 respiratory failure. Then patient becomes bedbound. Patient becomes dependent for a lot of their activities, and hence you have to do a adequate care like a frequent bed change or position change, because there is an increased risk of pressure source. So there is an increased risk of pressure source, right? So as you can see, this is a devastating diagnosis to have. Patient becomes bedbound, completely different, cognition is intact, right? So that is why you should be very careful about your ALS diagnosis and how do you manage it. So how do you diagnose your ALS, right? How do you diagnose your ALS? So how do you diagnose your ALS? On the electromyography, so what we do is an EMG finding. So we see that 4 regions have to be involved, right? So what are the 4 regions where you see evidence of? You see for evidence of denervation. You see for evidence of denervation and destruction of anterior horn cells. So what are those areas? You see the bulbar, cervical, thoracic and lumbosacral spine. So if 3 out of 4 areas you have found evidence, or 4 out of 4 areas you have found evidence, then this is a definitive ALS. Okay, then this is a definitive ALS. If 2 out of 4 areas, then it is probable. 1 on 4, it is a possible ALS. Okay, so this is how you diagnose it. But before we jump on to all this, when you see an overall approach to ALS, right, how would a neurologist look at ALS? You will have to do a complete head-to-toe evaluation. Like I told you, rule out all the other etiologies that for ALS that we had discussed, right? So what all you would like to do? You will have to do a MRI whole spine. You will have to do a MRI whole spine plus MRI of the brain. Why would you want to do that? Because you have to rule out other etiologies such as the demyelination, which can also present with predominant human symptoms. Okay, you will have to rule out compressive myelopathies, you will have to rule out non-compressive myelopathies. So that is why you do that. Then you have to do a CSF examination. CSF examination is basically used to find out if there are any infective causes which are causing your ALS, right? Like your polio, HIV, any other viruses which are causing your motor neuron disease symptoms. So in ALS, the CSF is going to be normal. The CSF examination is going to be normal. Then you need to do your nerve conduction studies. Why? To detect other disorders like your MMNCB, right? You need to detect other disorders like your MMNCBs. Then you need to do a metabolic profile. You need to do metabolic profile including your PTH, because hyperparathyroidism can also mimic ALS, right? So these are about the various other tests you do before you do a complete diagnosis of ALS, right? Before you say this patient is having ALS, please do work them up fully. Now, let us move on to the treatment of your ALS, right? So, there are only 2 drugs which are used in the treatment of the ALS. They are not very effective drugs, but in this disorder, even prolongation of the lifespan by maybe 18 months or 2 years is a achievement, right? So, the first drug is Riluzole and the second drug is Edaravone. First drug is Riluzole and second drug is Edaravone. Okay, so Riluzole basically just prolongs the course of the disease by 18 months. Okay, Edaravone is an antioxidant. So it basically decreases the destruction or delays the destruction of the anterior horn cells. So sometimes Edaravone is combined with phenylbutyrate to improve its efficacy. But none of these drugs have been found to revert the ALS, rather they only help in decreasing the progression of ALS. Okay, fine. So most of the time the treatment of ALS is basically supportive measures, right? You need to give them a wheelchair. If they are bed bound, you need to ensure that you prevent the formation of bed sores or pressure sores. So you will have to do a continuous every 2-hourly position change, right? And you ensure that there is an air bed or a water bed, which basically decreases your bed sores. Then respiratory hygiene has to be maintained, right? Frequent aspiration has to be done because they cannot swallow their own secretions, right? So respiratory hygiene, frequent suctioning of the secretions has to be done. So frequent secretion suctioning, right? And also they may have high chances of aspiration, so they have to be on a Ryle's tube. Also, as the disease progresses, they can have type 2 respiratory failure, and hence there is a risk of deterioration as well, and hence you may have to give them a BiPAP at home as well because of your neuromuscular weakness. Bulbar palsy, again you will have to put them on a Ryle's tube. Okay, and if there is bladder involvement, the patient may have to be in a catheter as well, right? So this is about your amyotrophic lateral sclerosis and motor neuron diseases. Thank you.